Even before the COVID-19 pandemic, growing numbers of young people were experiencing high rates of clinical level anxiety. About 11.6% of kids had anxiety in 2012, up 20% from 2007. But during the pandemic, those numbers nearly doubled, such that 20.5% of youth worldwide now struggle from anxiety symptoms, according to a meta-analysis of 29 studies reported in the JAMA Pediatrics in issue number 11, volume 175 in 2021. So, with anxiety on the rise, my guest today is here to address it. He is Dr. Stephen Whiteside, PhD, a board-certified clinical psychologist, professor of psychology in the Mayo Clinic College of Medicine and Science, and the director of the Pediatric Anxiety Disorders Program at the Mayo Clinic in Rochester, Minnesota. He has written many books and has been involved in academia as well as research, and his research is focusing on improving access to evidence-based care for pediatric anxiety disorders and obsessive-compulsive disorder through the development of effective and efficient treatments facilitated by technology. And he is the author of several books already for clinicians, and he has published over 80 scientific articles. Today we're going to be speaking about his new book, Anxiety Coach, A Parent's Guide to Treating Childhood Anxiety and OCD. This is an essential resource to address anxiety disorders and OCD in children and teenagers, and he is a researcher and psychologist at the Mayo Clinic. All right, let's get to the interview. And welcoming to the Intentional Clinician podcast, we have Dr. Stephen Whiteside. Thank you so much for joining me today.
Oh, thank you so much for having me. I'm excited to be here.
Yes, and I'm excited for you as well to be here because you have written a book for parents called Anxiety Coach, A Parent's Guide to Treating Childhood Anxiety and Obsessive Compulsive Disorder, or as we call it, OCD in short. And I'm excited about this because this is going right to the consumer. You don't have to be a therapist or a doctor to understand this book, where some of your other books were written more for clinicians. So I appreciate that.
All right, great. Thank you. Yes.
So a lot of parents, you can read the statistics. I don't have them in front of me, but you can just Google anxiety rates since somewhere in the middle of 2013, 2014, and especially in the last 4 or 5 years, we're in 2024 right now, that anxiety is going up in terms of in the U.S. population in general, but especially with children and teenagers. That is just an unavoidable statistic. It's in so many news clips. And so this book is for those parents. And I think to really define what we're talking about, could you give us a little bit of basic background on the sort of some of the common forms of anxiety that you might address in this book?
Yeah, that's a great question, because that's actually where the book starts. The first section is trying to help parents figure out if what their child's experiencing is best described as an anxiety disorder. So we go over what an anxiety disorder is and what they tend to look like. So the definition that we use as an anxiety disorder is just quite simply that kids are more afraid, nervous, or worried about something than we would expect them to be. And that anxiety is causing a problem. It's getting in the way of everyday life. And kind of the main pieces of that are that it's anxiety, that what they're experiencing is nervousness and worry rather than anger or frustration or sadness. And the other piece is more than expected. And that's a crucial difference, because if life is stressful, if a parent is sick or a child's doing poorly with their grades or being picked on and they're anxious and worried about that, that's not an anxiety disorder. That's an understandable reaction to a stressful situation, and we handle that by trying to help them fix that situation or stay away from it until adults can fix it. But if an anxiety disorder is when kids are more anxious than we would expect, and the treatment for that is helping them face their fears. And within that group, there are a number of different anxiety disorders. Kids who just worry in general about everything. There are kids who are particularly nervous in social situations, kids who have trouble separating. We throw obsessive compulsive disorder into that mix, panic disorder. and specific phobias of things like animals or choking and things like that. That's what we mostly work with.
Yeah, absolutely. And I would say, as a therapist, it's pretty common for kids to have anxiety. The real issue is when it starts getting in the way of functioning and sleeping and what parents would expect as somewhat average milestones that a child should go through. So maybe let's give an example. Like you talked about multiple anxieties, including social anxiety, generalized anxieties, phobias. So maybe let's take a couple of examples of what somebody might see if their kid is sort of just suffering from general anxiety before we kind of go to I do want to cover obsessive compulsive disorder or OCD, but yeah.
Yeah. So generalized anxiety disorder is when kids worry and feel anxious about lots of different things most days. When they're worried, it's hard for them to shake it. They can't just stop and put the worries aside. They get stuck. And also, it's to the extent that it's, like you mentioned, not only causing problems, but it's also leading to physical difficulty sleeping, being more irritable, being more jumpy, stomach aches, other aches and pains. And what that often looks like is worry about school and achievement. And that's one of the most important pieces of childhood. And so kids who are doing well in school, oftentimes they're getting straight A's, but yet they're still worried that they're not going to be doing well enough. So they're spending much longer doing schoolwork than, especially as teenagers, spending much longer doing schoolwork than they need to, rechecking things, studying, even though they're already set to do well on the test, and that's getting in the way of spending time doing other things. They're going to bed late, etc. They also can be just sort of worriers about safety. They're kind of concerned that they're going to get sick or hurt. If mom's late, they immediately assume that she's gotten into a car accident. If you're planning a fun vacation, they're automatically worrying, well, what if the hotel doesn't work out, or what if the plane crashes? It's always with the what ifs. And that can be really stressful for kids themselves and also for parents who feel like they're constantly providing reassurance. Little things that should be relatively easy and smooth to do take a lot of planning and help and to get their kids through them.
Yeah, and I think that it's important to note for parents out there that there is help available, multiple interventions, behavioral. This in particular is starting off with helping the parents understand it and apply practical knowledge, which we'll get to. But if something incredibly traumatic or tragic occurs in your family, you're going to expect possibly a period of time where a kid may be anxious or worried afterwards. But if it's just kind of there all the time, there's a lot of questions to start asking and seeing if this is debilitating them. Is this getting to the point where it's impairing their development in some way? What would you say about that?
Yeah, yeah. So when so post-traumatic stress disorder (PTSD) is another diagnosis like OCD that used to be an anxiety disorder and now is its own category, but involves a lot of anxiety. And that's a nice example to help kind of think through the difference between a anticipated, expected reaction to a stressful traumatic situation versus continued anxiety that's excessive and interfering with life. Because if something traumatic happens, we would expect anyone to respond with anxiety, fear, sadness, anger. And those feelings last for a long time and can last for a while. But at some point, it makes that transition to that traumatic episode is over. Life now is safe. That trauma, that dangerous situation is no longer occurring, but the memories, the nightmares continue, and it's those recollections, those memories that cause the impairment. But similarly, along those lines, most kids with anxiety do not have a traumatic episode that set it off. I think a specific phobia, like fear of dogs, is a really nice example because you would often expect that child's afraid of dogs. Well, probably something bad happened. They had a bad experience with the dog, it chased them, or they got bitten. But more common is parents will say, you know what? They just always been afraid of dogs. Nothing's ever happened. They just always have been. And because that's just kind of where anxiety disorders come from. There's a genetic component to it that we've kind of just inherited a tendency towards anxiety. Doesn't mean everyone with anxious parents is going to be anxious, but we have more of a likelihood. And then also just a pattern of avoidance. And that's something we talk about early in the book, in the third chapter, is understanding kind of how kids avoid what makes them nervous, which not only keeps their anxiety around, but can actually make it get worse and worse over time, because they don't feel safe until they've avoided it or gotten out of it. So they start avoiding more things. That's a quick way to feel better. And that natural learning process can take a low level fear or worry and turn it into a more extreme one, even though nothing traumatic or upsetting has happened.
Aha, I think we're now getting into possibly a little segue, a temporary segue, because I got more questions about OCD, but about the fact that as children are learning and developing, the environment, the parents, the school, these experiences can play a big role in whether or not their genetic tendency for anxiety or depression or whatever kind of gets triggered and sort of can continue to get worse. Like you said, the avoidance, right? And so I think I've heard anecdotally in the community, some parents realize their kids are afraid of a playground, or they're afraid of a dog, or they're afraid of birds, or they're afraid of spiders, or whatever. And they sort of reinforce that. They say, oh, yes, well, we should avoid those places. We're only going to
Mm-hmm.
go to this place, or we're only going to hang out with people that have cats, and we're going to spray our entire house with chemicals so there's never a spider you'll ever see. And what can you explain to me, what might that do to a child who's already developing some anxiety?
Yeah, yeah, and so that is so that that's our general model for how an anxiety disorder develops over time, and that it's that model that informs how we're going to later intervene. And so the basic idea is that when uh, when we're when we're in a situation that is frightening, no one likes to be afraid, so we avoid it. We get out of it. We have our parents help us, or have our parents help us avoid. Or for OCD, we do some rituals, and that makes us feel better, so that we avoid it again the next time. And so, especially with kids, it's true for kids and teenagers, especially younger kids. A big part of problem solving and handling new situations is turning to your parents. And so that parent help, either I can only do the situation if I have my parents to help me through it, or parents help avoid, like the examples that you explained, work really well in the moment to remove that fear, calm things down, keep things going day to day. But it prevents kids from learning through their own experience that life generally works out. Things are not as dangerous as I thought, and even when things are hard or upsetting, I can handle it myself because I've been through it and I've done it. Um, and it's a natural response from parents. I mean, I'm a parent. I don't like it when my daughter is upset and anxious. I love it when I can swoop in and fix things. It's a great feeling as a parent, and there's nothing wrong with that, except when what sets off their anxiety is not dangerous, and it becomes a pattern and a habit that the only way they can handle this is by me helping them avoid. That's when our responses can make the anxiety worse over time, rather than helping our kids get through it in the moment.
Yeah, that makes sense. And the children are learning, they're absorbing, how parents react and how teachers react and how the
Yep.
community reacts. And I guess that's kind of the point. One of the points of your book is helping parents understand anxiety and recognize the disorders and the issues, but also how do they then address it at home and or with treatment and other modalities. And so with that, would you say sometimes that people avoid stressful and anxious situations too much, right? And we're not like dose. Bruce Perry talks about dose dependent exposure, like kind of like giving a kid, like, you don't just like put the kid on the bike and push him down the hill. You kind of like start with training wheels. You start on an
Yeah.
even surface, right? And like kind of start exposing them to, as they're learning, a little bit of fright at a time. I sort of see that when we were talking about your book notes over here. Um, do you think that if they're learning in a way that's like supportive and constructive, that could eventually possibly decrease the anxiety?
Yeah, that's the whole idea behind exposure therapy. And so, as I mentioned, the first part of the book is helping parents decide whether or not what their child's experiencing is best described as an anxiety disorder or OCD. And then the second part of the book is saying, all right, now that we've decided it's anxiety or OCD, what are we going to do? And
Mm.
since kind of our understanding of an anxiety disorder is being more afraid of something than would be expected. So the situation is relatively safe, but we feel nervous. And the reason we haven't learned that it's safe and we can handle it is because we've avoided it. That leads us naturally to the treatment, is to face our fears and learn through our own experience that what we're afraid of probably won't happen. We can handle feeling anxious until that feeling goes away. And even if things don't go well, we can handle it. And as you're mentioning, that that's hard. And so we don't just, if you're afraid of dogs, we don't just throw you into the dog park and tell you to come out when you're not afraid of dogs anymore. We have to take small steps because it's hard, and it has to be at a level where kids can be successful, manage it, and pay attention to the fact that things turn out better than they want. So that's where second half of the book, or second part of the book, is kind of walking through the history of exposures, kind of the generalities of what it is, and then getting more and more specific of this is how we do it with kids.
Okay. And I guess we'll just lean into that for a minute. Bringing in this sort of parent coach exposures from your program, which is in the second half of the book. It's different than cognitive behavioral therapy, from what I'm understanding, and you're actually coaching the parents to do some of this at home. Can you, without giving everything away, because you need to buy the book,
Yeah.
can you explain a little bit of how maybe a parent might do that with like, let's just say a child who's afraid of dogs, just because maybe they've never been exposed to a dog,
Yep.
or they saw a dog on TV bite somebody, but they've never been bitten themselves, right?
Right. Yeah. So the steps, so the general idea is that we all learn best through our own experience. And if it was as simple as parents just explaining things to their kids, this is safe, then parents will just handle it on their own. And so we need to help kids face their fears. That's hard to do. And so the first piece is understanding the child's, what they're afraid of, understanding how they've been avoiding, what they're afraid is going to happen. And then we set up these little experiments called exposures, where we take a fear, we break it down into small steps. The fear of dogs is a nice example. We call it a fear ladder, so a list of things we're going to do to practice facing our fears. That might start with just watching videos of dogs barking, makes you a little uncomfortable, but not too overwhelming. It's a successful exposure, and then we can pet a small dog and kind of work our way up to bigger dogs in harder situations. And so what we do in our program is, after we've kind of taught families about how this works, made a fear ladder, in each session, we're just helping them do an exposure. We're helping them pick something, make an experiment by saying, this is what I'm afraid is going to happen. And then kids do it. They pet the dog, they touch germs, they start conversations, and they just keep doing it, do that small little bit over and over and over again, over about 15, 20 minutes. And eventually what was frightening gets boring because nothing bad's happening. And when their anxiety is down, then we say, all right, now we're done. And there's two things we want to make sure we learn. Number one, did your fear come true? Most of the time it's no. It might be yes, but it wasn't bad. I was able to handle it. Then secondly, what happened to your anxiety? And most of the time it came down, but sometimes it was hard. My anxiety stayed high, but I was able to do it. And just the general conclusion should be, that wasn't so bad. I'm willing to do it again. And so we spell out the steps in our program. We teach parents how to do that in the session through their own experience of doing it with their child, with our assistance. And then they practice at home. Then they come back and we help them take the next step.
Yeah, that really makes a lot of sense to me, because with children, cognitive behavioral therapy is sort of like explaining things and like your distorted thoughts, and
Yeah.
what are you anticipating, and how does that cognitive thought affect your behavior, and how is your behavior affecting your cognitive thought. And I feel like that's a little complicated for the kids. So I actually like this idea of them like doing these little micro tests with the parents around, so they have that comfort factor. And then reflecting afterwards, how did that go, and what did you feel, and because it's allowing the child to sort of make their own conclusions, where a cognitive behavioral therapy intervention may be like the adult saying, well, here's how it could be, and you should go try it, and next time you're on a dog, there's nothing to fear, you do this, that, and the other. I think it makes a lot more sense to learn from experience. And as we know, according to a lot of behavioral literature, people tend to learn best from their own mistakes or exposures or experiences, which is why having this sort of protected and safe ability to have an exposure to something fearful, what I would almost say, it's not only exposure therapy, but it's also like kind of an experiential therapy, which isn't really a therapy name, by the way. I just made that up. But it's sort of like an active learning for the child, in a way that they can feel proud of themselves too. I feel like there's some learning about like, wow, I did that, and you were here, and I feel better about myself. Like the self-esteem possibly could be affected as well. Any thoughts on that?
Yeah, no, that's perfect. And I will just reiterate a little bit of what you said because I think you nailed it. Um, that is exactly the difference between parent coach exposure therapy and traditional CBT. And there's a lot of research, a lot of literature that CBT is helpful for kids'
Sure.
anxiety. And CBT usually, the kind of the most researched one is you spend the first half of treatment learning how to identify emotions. You learn how to do cognitive restructuring,
Hmm.
problem solving, relaxation strategies, uh, based on this idea that kids need to learn how to relax to tolerate exposures and then do cognitive strategies to learn from exposures. And that's a lot of treatment. And from early on, there was suggestion that that first half was not really leading to improvement. It wasn't until they did the exposures in the second half. And so the first component about what makes our approach different than traditionally researched therapy is that we start with exposures from the beginning. We spend typically one session explaining things, uh, making a fear ladder, teaching them how to do exposures, and then from there on out, each session is doing an exposure in the session with kids and parents together, having them practice on their own. And then the second piece is therapy is usually individual with the child, parents at the beginning and the end to sort of kind of check in. We're working with them together the whole time because we don't think facing your fears is hard work and who's going to do it. So having your parents there at home, one, to help you do it, two, to keep you on track. And when you're anxious, you go to your parents. So your parents need to know how to handle that. So you really summed up the difference. And the reason that we wrote this book now, I firmly believe that parents can learn how to do this because that's what I've spent the last 20 years doing is teaching parents how to do it. So I've seen it. And I wanted to write the book to encourage to have more people have access to this type of treatment, but I didn't want to do it until I felt like I really could prove that I had something valuable to say. And so a few years ago, we had the opportunity to compare our treatment in a randomized controlled trial to traditional CBT. We finished that study and it suggested that our treatment was more effective with fewer appointments. We're in the pot. We're just waiting for that to get published here, hopefully soon. Once we had that data, I felt like, well, that's enough support that it's worthwhile to write a book. I've got some credibility for why I'm suggesting parents take this approach.
Yeah, that sounds great to me. And I think, bringing getting the parents educated and involved in therapy, as long as they are, uh, happy parents that are trying to not be abusive or neglectful. Of course, that's a whole other topic
Yeah.
of therapy. But if they're just, your average parent is very concerned and trying to help, can be a game changer for me. Just on anecdotal level, whenever I have at the clinic I work at, whenever we have a child under 18, if appropriate, we try to bring the parents in for at least some family therapy to try to help the child and the teen get through whatever their issue is, right? This may not be exactly what you're treating, but just anything really, because if you can get the parent to then model the behavior you want at home or use some of the therapist's ideas or some things from some book you read, the kid is going to recover so much faster than if you're just treating them in isolation, right? You're just like, okay, here, the parent's busy. Oh my God, my kid's freaking out about this or that, or they're depressed. Here, I'm dropping them off. I'm going to go in my car and work on my work. Getting involved in the therapy instead of sitting out there in the lobby can really be impactful. So I'm excited for your study to come out. And also on the opposite end, there are some parents out there, I'm just going to throw this out here for an example, who kind of take the old school John Wayne approach. There was an old movie where John Wayne was, I think, dating some woman who somehow had a child already, which was a huge scandal in the cowboy era. And in the movie, the child is kind of a stereotype boy who is afraid of everything. And the boy says, and John says, you gotta cross the river, son. You gotta cross the river for me. And he's like, I can't swim. I can't swim. And the mom's like, he can't swim. And everyone's, like that. And John Wayne said, well, the way I learned is you just throw him in. So he grabs the kid, throws him in the river. Thank goodness, of course, Hollywood stunts. The kid, did not drown. He swam to shore and realized, oh my God, I can swim. And then the wife and him fell in love. And it was, but what I mean is this old school idea that like somehow, so I would call that like a classic projection of the parent saying, well, I did it this way. Why can't my kid do it this way? We have to get a therapist involved. That sounds absurd, right? So like, how do we help parents who have these sort of expectations that their child should be able to do something that they did at that age? And I threw that cartoonish example out there just as kind of an extreme kind of humorous idea to kind of hear your thoughts about that sort of attitude.
Yeah. No, and so we encounter, not surprisingly, we encounter both. One, parents find it are reluctant, or it is upsetting, anxiety provoking for them to have their child do exposure. So they end up not pushing hard enough. And then we have other parents, either because they don't have much anxiety themselves, they're sort of frustrated and burnt out. They're excited and just mostly they're excited and want to get their child better, and they're over exuberant and they push too hard. It's our job as therapists just to help the parents learn. And we don't expect parents to know how to do this, to help them learn to meet in the middle. And so one of the pieces of kind of the second section of how you do exposures is putting together a motivation plan and kind of what the parent's role is. And the first step of that is taking small steps. That if parents push too hard, kids get angry and push back, it doesn't go well. Nobody learns from the experience because they're spending all their time and energy fighting. But I think it's really important to include all those, because the alternative is this parent pushes too hard. So we're not going to include them in treatment. They just got to back off and we're just going to work with the kid. And then, well, that's not going to go anywhere, because when the kid leaves your office, the parents going to keep doing whatever they've normally been doing. And when the kid gets anxious and comes to them, they're going to respond the same way. Same thing's true for kids or parents who are overly anxious and don't push hard enough. If we don't teach them to do something different, they're not going to do anything different. And get back to the cycle or kind of the system you were talking about. We need to change the system, not just the child's behavior. And parents learn from their experience better than being told what to do, just like kids do. So if parents are there in the session and they are either, I'm really nervous, I don't think my kid's going to be able to handle this, or it's too painful for me to see them suffer. The child does the exposure, gets really upset, calms down, is successful, feels great. Parents saw that happen. They say, oh, wow, I feel more confident I can do this. Same thing with the parent who's like, this is ridiculous. Why should we take this long? And they're never going to do it. Sits patiently because they're here in public with us and their child does it and is ready to do the next thing. And the parent says, oh yeah, I can see how this can work. I can do this. So we think parents can learn best of their own experience, just like the rest of us.
Well, that is very wise counsel, and looks to be proven in the literature about participation in therapy. So one thing I guess I would say is a lot of your book here for parents was based on the research, based on your previous books, based on this exciting study you're going to be publishing soon. And you've got plenty of other articles, as people know from when I read your biography before the interview. But in some situations, your book may be appropriate for some parents to try before going to a therapist. Can you explain, maybe for the parents out there, hey, you know what, Dr. Whiteside, your book is $20. I'm going to buy that book immediately. I'm going to try this out. And then, lo and behold, it works, or lo and behold, it doesn't work. So can you kind of explain maybe to the parents, when do you need to seek clinical intervention versus when you might be able to do it at home? Obviously, this is not a universal. This is, you have to obviously do your own diligence, but what are your thoughts on that?
Yeah. So there's two goals with the book. And so my intention, aspiration is that there are hopefully a number of families out there where their child's anxiety or OCD symptoms are relatively mild, and that just simply by reading this book, getting a general sense of this is what we're supposed to do, let's sort of talk it through, let's work through it, that this can be enough to nip it in the bud so that anxiety or OCD doesn't become worse, and that they get things going in the right direction. But I've been doing this long enough to know that us teaching people, explaining things and teaching people what to do is a very easy part of the job. The hard part of the job is being with people and supporting them in a warm, caring, and knowledgeable way that they can trust you to help them do it, because it's hard. And so for many families, if anxiety or OCD is more moderate or severe, reading a book is not going to be enough. But it is really hard to find a therapist who does exposure treatment. And that's why we have an intensive treatment program here so people can travel and do treatment with us. So by reading this book, parents can learn, okay, we can't do this on our own. We gave it a try, it didn't work. We're not even going to try because it's overwhelming. But now I know what therapy looks like. Therapy is not sitting around and talking about problems or talking about what I might do in the situation. Therapy is not the therapist telling us to go do exposures on our own. Therapy that's going to be effective is doing exposures in the session so we feel confident we can do it outside the session. And now I know what to look for. And when I go to a therapist, I can ask if they do this, and they say, no, I don't do this. We're just going to play and talk about it. You can say, well, that may be good for some things. It's not what my child needs. And they can go find another therapist.
Yeah, I think that's a very, very good point. There are exposure therapy is kind of what you're talking about in this book. And I think that's important to know the type of exposure and all of that. So I think I think the best idea would be, in my mind, would be the parents buy the book, see how it works. If it doesn't work, use the book and go to a therapist.
Mm-hmm.
If you can't find an exposure therapist, one of the things that we've seen in my clinic is a lot of the therapists are trained in EMDR therapy. And this is not studied for EMDR. The EMDR studies are not conclusive on this. But one of the things that they were creatively doing was bringing up a picture or something that they were afraid of, and utilizing the EMDR therapy on the kid with the picture, with the parent in the room. Sort of worked, in some cases worked well, but this has not been fully studied. But that might be another alternative to just talk therapy and play therapy, which we're not going to get them exposed to the difficult material as much. It's just like telling them how to deal with it versus showing them how. And that's kind of an old proverb, which is like, if you show me how I can do it, if you tell me I'm not going to be able to fully do it. And the exposure is actually doing it with you, which I think is amazing, because if you look at like learning theories with kids, they're always talking about scaffolding, right? Like we have to build the next scaffold on a building to be able to make the next layer. Just like that with kids, we want to scaffold a place where they can be safe, where they can learn that they can climb up this fear ladder to the next level. We then show them that they can do this because they're doing it with us, right? And that's the big emphasis I hear in your book so far. So I think that's great.
Yeah, and that's really important. I just wanted to just mention that even though we're not doing cognitive behavioral therapy, we're not focusing on these strategies, we definitely believe that learning and cognitive change is really important for the treatment of anxiety. Just piggybacking on your point is that our assumption is that learning happens best with experience. Learning doesn't happen best by filling out worksheets or thinking about what I might do. Learning happens best by paying attention to life, doing things that are new and paying attention to what happened. And that is a powerful learning experience.
Absolutely. So I am very curious to hear about the obsessive compulsive disorder, or OCD, which we will now call it to save ourselves a little bit of time here. Can you talk about I feel like this is such a misunderstood disorder and an issue with people out in the community. Can you explain a little bit about what OCD is and what it's not?
Yeah. In the book, the second chapters, we go through each of the anxiety disorders and kind of explaining them, including OCD. And so OCD is obsessive compulsive disorder, and it has two main components. The first are obsessions. And so these are intrusive thoughts or urges that cause distress, often fear and worry, anxiety. So I had the thought that I now have germs on me from touching the doorknob. That thought makes me very nervous that I'm going to get sick and die. Um, I have a weird intrusive thought that I'm going to hurt myself or hurt somebody else. It comes out of nowhere. I'm not angry. I'm not sad. I just had this thought because I saw a knife, and that's very frightening. And so those intrusive thoughts are the obsessions. And then the compulsions are having to do something to get rid of that thought, to fix it, to make yourself feel safe. So with the germ example, I touched the doorknob, the intrusive thought, I'm going to get sick and die. I feel very scared. I wash my hands over and over again. I feel better. Now I'm stuck in this loop that I have to wash my hands every time that I think um, I have germs on me. Or I see a knife. I have an intrusive thought that I'm going to stab someone. It makes me very scared. So I put my hands I sit on my hands so I can't grab it. I put knives away. I ask my parents, am I going to stab someone? They no, you would never do that. I feel better if I'm stuck in this cycle. Now, so OCD used to be in the group of anxiety disorders because many of the flavors of OCD involve fear and worry. But it's a pretty heterogeneous disorder. Some people don't want to touch germs, so they're afraid of germs because they're going to get sick. But other people are just grossed out. It's like, I touched all these public places. Who knows what other people are touching? Now I've got all these germs on me. It's disgusting. I'm not going to die, but I'm not going to feel good until I wash it off. And then you've got this just right OCD, where some people say, if I put this cup down wrong, someone's going to die. So I better pick it up, put it down, pick it up, put it down until I have a positive thought and everyone will be okay. Other people say, I put it down, it just feels wrong. I got to pick it up, put it down, pick it up, just till it feels right. It's nothing bad. It's just an uncomfortable feeling. And so because there's that wide continuum, it's now in its own category of obsessive compulsive and related disorders. But we combine it together because the treatment for OCD is exposures with response prevention. So you got to touch the germs without washing your hands. You got to repeat the scary thoughts without redoing things or asking for reassurance. So the treatment is very similar. And actually, our treatment for anxiety is more exposure based than traditional treatment for child anxiety, partly because some of my background came from training in OCD, which is very exposure focused. So we treat them both the same. So we in our clinical practice, we have groups of kids with anxiety and OCD together, and we just all work on facing our fears together. So that's why we include it.
Oh, that is very good explanation. I appreciate that. And I actually, I love the idea of groups. I feel like since the pandemic in 2020 and beyond, there's been a lack of groups for kids and therapy groups in general that I've seen advertised. I really wonder about how the treatment would go versus individual when you have a group of like-minded peers who are all scared of the same thing, all facing their fears together. Could you maybe elaborate on that?
Yeah. Our groups, whether it's the once a day, once a week local group, or it's the intensive program where we're doing 9 group sessions over a week, we combine kids of all age, 7 to 17, combine kids and teens together. We always have, the child and one or both parents there. And it is a mix of all different fears and worries. So usually about half the group has OCD, half the group has anxiety disorders, which are mostly generalized anxiety, social phobia, and separation anxiety. And we begin each group by reporting in what we've done since we last saw each other. Then everyone breaks apart, works with their parent to do an exposure. And then we come back and report how it went and what we're going to do before the next group. And so one reason we do groups is that it allows us to have good access so that people can get in more quickly, don't have to wait as long. But also, although many people are nervous, uncomfortable at first, being in a group with other kids and families going through the same thing is really normalizing. It's like, hey, all these other normal, cool kids have this as well. It's not such a big deal. I'm not alone. We're not alone as a family. And that's really helpful. Also, they can support each other. They know what it's like to go through anxiety because they're going through it themselves. And especially with the socially anxious kids, if you got to do exposures to talking to kids and talking in front of a group, it's pretty handy to have a group of people there to practice with. So we don't know whether it's more effective to do it individually or do it in group. We should do that treatment study at some point. It needs to be done. And it probably varies. I mean, some people need more focused attention to make sure that they're getting the exposure done in the session and getting them done between sessions. Some people probably need to be in a group where they can be interacting with other kids because that's part of their exposure. So we don't know which is more effective, um, but the most rewarding thing are these intensive groups where we've got a group of 6 to 8 kids and their families, and they come on Monday and we see them twice a day through Friday. I just wrapped one up earlier today, and the progress they can make in 5 days, the kids make in 5 days, is astounding.
Well, that sounds incredible. Yeah, I mean, it. You're right. It could vary for per person, but it just the idea that these things are available. And is this all at the Mayo Clinic in Minnesota,
And
Rochester?
yeah, Rochester, Minnesota. We have our 5-day intensive treatment program, and we've got most of the kids are from the regional area. Not as many from Rochester itself, because if you're in Rochester, it's more convenient to come once a week rather than take a whole week off. But from the surrounding area, the surrounding states. But we've got kids from all over the country who travel to come see us.
Oh, that's wonderful. Um, so one of the things you address in your book uh, is school, friends, and family, how to use children's quote jobs as a benchmark for anxiety. Could you
Yeah.
explain that?
Yeah. Well, this goes back to your point from the very beginning that anxiety is a problem when it's causing impairment in a child's
Hmm.
life.
Oh, I see.
And and one way just to kind of make that more concrete is think about what do we expect kids to do, and if they're not doing it, then that suggests there's something as a problem.
Hmm.
And so the way I phrase that is that kids have 3 jobs, in no particular order: school, family, and friends. So we expect kids to go to school regularly and do their schoolwork. They don't have to be straight A's. Kind of the level of academic achievement varies for kids and families and what's expected, but they need to be going to school and doing schoolwork. They also need to be part of the family. They need to do chores at home, be relatively pleasant at home, do family activities, kind of do things with the family. And then third, and that is social, doing things with friends, being in an extracurricular activity or two, doing things outside the home. And kind of the way those are done changes developmentally. But I like to call them jobs to kind of make it clear that these are important things. And going and having fun with friends should be fun, but it is like an important thing that kids are doing. They're learning they're learning developmental and complex social interaction skills. And so that's an expectation of what they need to be doing. And so when families are trying to decide, is this a problem? Is anxiety really getting in the way? Do we need to do anything? We can look at, well, do they have 1 or 2 friends? Are they in extracurricular activity? Are they going to school? Are they getting their homework done? Are they doing things at home? If yes, then maybe we don't need to work on anxiety, because as you also mentioned, everyone's worried. Everyone feels nervous about things, and that's normal. And sometimes it's fine to be overly quiet or overly worried, as long as it doesn't get in the way of those jobs and kids are content with it. Then maybe we don't have to spend our time and resources going to the doctor's office.
That definitely makes sense. When I was looking through your book, you spend the whole first half kind of defining what's going on so parents understand. And in the second part, it's more about introducing exposure therapy, the parents' role in exposure therapy, the different types of exposures, whether it be thought or in person or another type. Um, I'm just curious now. Are you working with your research to try to possibly make exposure therapy more prominent in the therapy world for these type of issues with children? Is that one of your goals, or is that just like or you just follow the research?
But that's a hard question to answer. Of
Okay,
course, I dispassionately follow the research. I have no skin in the game, nor no horse in the race.
sure.
Um, but I mean, like I'm human, and we all are driven by our passions and our beliefs. So I from early on, based on my view of the research and the training that I had received, it seemed clear to me that exposures were where the most improvement happened, and for all the reasons we've talked about. Some of them looking at data, some of them just common sense. We learn best from our own experience, doing rather than talking about it. It seemed like that is where the the change happened. That was what was most important for kids to do, but that there was very little of it happening. Therapists tended not to do exposure. Even the treatment packages, I thought, were not focusing on exposure enough. So I've spent the last 20 years trying to do research about understanding the extent exposure therapy is available, and it's kind of culminated into this research study. And so, yes, I think my professional, the main thrust of my professional career is trying to make treatment for childhood anxiety disorders and OCD more effective, efficient, and accessible. And we do that hopefully by doing good basic research that demonstrates we're on the right track and we're following the data, and of how we design our treatment for parent-coached exposure. We trying to disseminate it by writing research papers, giving talks, giving presentations, writing books. We have spent a lot of time trying to figure out how can we use technology, building websites, building apps, building platforms to increase awareness and access to evidence-based treatment.
Yeah, and another thing I admired about your mission, at least I know you're following the research and all of that, but the way you're writing about this is very destigmatizing. I think oftentimes, in the medical literature, it's like, oh, this disorder your child has, and how, people kind of get hung up on that. And so then that creates kind of like, it can create many things, but here's just two examples. The extreme, which is, oh my God, my child's so sick. They're so screwed up. Oh my God, I need to get them on all the medications, go to all the therapies, do all these things. It's like sort of overinvestment. Then the child starts identifying like, oh my gosh, I'm a sick person. I am not a normal kid. Or the opposite, which is complete denial. These are the extremes. Like, oh, this is horse crap. My child's fine. This is they're just going through a phase, and then they don't address it. And then they launch the kid off to college where they have a complete mental, breakdown or whatever after 18. I've seen this, the cultural responses to it. So, parents have such a huge impact. And I do think that this book is like, okay, this is normal. Everyone has worries. Like you said, like this book could just help tons of people who are at the subclinical level of anxiety, but it's starting to build up. The parents have the right tools instead of kind of using these, whatever the parent was taught or whatever the culture is sort of saying to kind of intervene. They're using evidence-based techniques that are not easy, but learnable and accessible is what I heard as well. And it simplifies it. I think that's the other thing I liked about it, was that it's simplifying the issue. And you're in a way, you're going, okay, let's try it this way and we'll see how it goes. And then you'll be able to figure out what are the other issues, right? So like, this is strictly treating these anxieties, phobias, OCD directly. Now, as we know, with people are very complicated. So there could also be like self-esteem issues. There could also be a sleep disorder connected to this. There could be extreme beyond normal hormonal melancholy that teenagers get. It could be like extreme depression that's sort of hidden underneath this. And so I do love how that is just really breaking it down, because I almost feel like this is like, you are able to, if you try this out and if it works or it doesn't work, it kind of gives you more evidence as to what needs to happen next as the parent, versus sort of just I keep going back to this, but like the wheelbarrow, dumping my kid off at therapy, see you later in an hour, fix my kid, which no offense, parents, but a lot of you, I mean, that was an extreme example, but a lot of you do that. You kind of have these expectations that the therapist is some sort of wizard and the psychiatrist is like a medicine healer that's just going to like fix your kid. And you don't understand that the kids are yes, we can help, but an hour or a medication, an hour a week or a medication is only doing so much. So we need that participation of the family system. We need the kid to have more tools. If the medication's appropriate, then we should think about how long are they needing to be on this medication? Is this some sort of permanent disorder? Is this fixable, right? And so I guess what I would say is, what about those parents who are just so frustrated right now? They don't even know where to start. They're like, obviously my kid's anxious. but they're also vaping and they're also angry and they punched a hole in my wall and they're screaming and they're isolating and sitting on their computer in their room, which take the computer out of the room. But they're cussing out their aunt and uncle. What do you do when you don't know where to start?
Yeah, yeah, that's a great question, and one that there's not an easy answer to. And so, in that second section of the book, we have got a chapter on what else might this be. So one, what are other symptoms and mental health disorders that might be confused for anxiety disorders, or what are symptoms and disorders that occur with anxiety disorders that might have to be treated first. Making things simple and easy, starting with anxiety. If a child's more afraid of something than they need to be, we'll help them do exposures, unless there's something that's going to stop that. The common things that stop that are anger outbursts. It's very natural. The fight or flight response. When you are scared and nervous, your body turns to fight or flight, so you run away or you get angry and fight. So that's normal. But if that is so extreme that kids just won't cooperate at all with our treatment process, or if they're just kind of oppositional and hitting aunt and uncle in general, whether or not they have anxiety, whether or not their anxiety is leading to those anger outbursts and lack of cooperation, we need to get cooperation first. So then we will work on behavior management, family therapy to get cooperation. That might mean we continue to avoid anxiety-provoking situations until we get the cooperation and then do exposures. But cooperation has to come first. Sleeping and eating issues. Nothing goes well when you are not sleeping or eating. So if your anxiety disorder, fear of choking, fear of vomiting, fear of contamination, poisoning, stops you from eating, and then now your body is much lower weight than it's supposed to be, you don't have the gas in the gas tank to manage your emotions, think clearly, be able to participate in exposure therapy. So we got to help you refeed and gain that weight back before you're going to be in a place where you can actively participate and learn from exposures. If a kid's sleep cycle is completely off, so they're up all night sleeping during the day, and we can't just start doing exposure therapy in the middle of that. We got to help the family get basic sleep and hygiene. So some of those fundamentals have to be addressed first. And so usually we need to have the daily functioning needs to be able to occur first before we can work on anxiety disorder. General safety, if a child is hurting others, hurting themselves, suicidal, that needs to be addressed before we can work on anxiety or other things. So we try to prioritize it by what is most problematic, what is causing risk of danger to self or others, before we can treat those first, then see what's left and work on the next one.
I think that's very wise to do the triage and the risk assessment, as well as what is the number one most dangerous or acute symptom occurring. And I think you're talking about the obstacle to cure. So sometimes this is just like anecdotal stuff. This is not research, but I talked to some therapists that were having trouble. The parents were complaining that the child wasn't sleeping. Okay, so the first thing they said was, is their phone in their room? This is before going to the doctor for a sleep disorder. Sure enough, their phone was in their room and they were on it all night. So then they took the phone away. This is a great spot. So kids, if you're listening, don't listen to this part, but you lock it in the trunk of your car and then you put the keys in your bed. That's a parent tip. They won't find it. They'll have to wake you up to get it. So, that helped that kid sleep, although they had an extinction burst of anger with the parents when they took the phone after 10 p.m. Another couldn't sleep situation. The parents found out that the child was going to a gas station after school and getting a giant Monster drink, which is energy drink. Sorry.
Yeah.
Don't send me a cease and desist. Those work great if you need to wake up. And they were drinking this 16 ounces of caffeine. It was like the extreme one. It has like 6 cups of coffee in it or something. And then they were like, I can't sleep. And the parents were freaking. So in both cases, the obstacle to cure was removed. And then, okay, now they're sleeping. Okay, now what's the issue, right? And so you're kind of going, okay, what is the main issue first? Obviously, anxiety is important, but if it's not life threatening and it's not impairing their physical health, we need to fix what could be impairing physical health. And like you said, if you're not eating, you're not sleeping, you're not drinking enough water, we can't even tell what's going on. How are we supposed to have a differential diagnosis? It could be like any one of six things. It could be something physical going on, right? And so, I think that's very, very wise to seek counsel if you're a parent that doesn't know what to do. Um, I'm a big fan of parents getting multiple opinions and assessments because if you don't know what you're treating, the therapist, sees you and you think you're treating one thing and it's another. That's not going to be very effective, right? So we want to make sure we get doctors who know what they're talking about involved, therapists who have a track record of working with teens and kids, maybe a psychologist to do a possible assessment. We want to spend that time up front because that is the time of prevention, right? We want to get a few books, see if these books work, like Dr. Whiteside's book. We want to get that and see if this is going to help at home before maybe, if it's not too scary or acute at that point. I think that it is important to spend the time up front. And the earlier, I want to know your opinion. My thought is the earlier you intervene on this, instead of waiting until a crisis where they have to go to no offense, I'm not saying the intensive people waited, but I'm just saying, because sometimes it's just intense symptoms. But like, for instance, I don't want to get to the desperation point where I have to put my kid in a hospital or an intensive outpatient or fly them to Rochester, Minnesota for a week. Do you agree on the earlier prevention? I'm just curious what your thoughts are on that earlier intervention.
Yeah, I work with kids, so part of that fundamental thought is that if we can address things when they're kids, it's more likely that they're not going to have these problems when they're adults. And I'm glad you brought that back to kind of what specifically parents can do when you're feeling overwhelmed. And another point you brought up earlier, that there are mental health treatments, there are solutions, things can get better, and I would encourage all parents to seek help. And usually what that means is going to the pediatrician family doctor because 90, pretty much all kids, more than 95% of kids have primary care. And so that is usually the first place that people turn. Parents always tell, like when we ask them, what would you do if you have concerns about your child's mental health? They all say they go to the pediatrician. Pediatricians are trusted experts. So that's a great place to start. And that pediatrician may not be an expert in mental health. They have to, pediatricians and family doctors are supposed to be experts on everything. So they may not be an expert, but they can help triage. They can help give you a general idea of what this likely is or what needs to be ruled in or ruled out, and get you to a therapist, because it can be hard just to just cold turkey, or not cold, just cold call, find a therapist. Who knows what we're supposed to be looking for? So it is very reasonable to go to the pediatrician as that first step.
Yes, I agree completely. And networking, with parents, using social media, researching, after the pediatrician, researching therapists that may be available in having this sort of expertise. So I'm actually curious about this. Are you going to ever, or is there a network of therapists that could list themselves as using, exposure therapy methods or your methods eventually? Is that something in the works?
Yeah. So the mundane, immediate answer is that there are a number of good websites, and we list these in the back of the book. Finding Help, the Association for Association for Behavioral and Cognitive Therapies has a great website where you can search for a therapist in your home area. Those therapists are more likely to do behavioral interventions than a therapist you just picked out of the phone book, as if anybody looks at a phone book anymore. The Anxiety and Depression Association of America is another good resource. The International OCD Foundation, one of the leaders in training therapists to do exposure therapy. All of these websites have a find a therapist. You can put your zip code in, and they'll find a therapist in your local area. another kind of aspiration that I've been working for 15 years to do this, so it's not going to happen anytime soon, is trying to build a digital platform that supports mental health assessment, child mental health assessment and treatment, and having our anxiety coach in there, and that so that we can know what therapists are doing, and the family knows what therapists are doing, because the treatment is done using the platform. So like the fear ladders are built in there, exposures are recorded, so we got this nice record of who's doing exposure and who's not. So, but that's not going to happen for. Hopefully, it happens before I retire, but I'm not going to guarantee it.
Okay. Well, that sounds good. And plus, people can contact you. Your information is going to be in the show notes in terms of the Mayo Clinic program. As people know, you have written books for therapists about exposure therapy for child and adolescent anxiety and OCD, exposure therapy for anxiety, principles and practice, second edition, and the current book, Anxiety Coach, A Parent's Guide to Treating Childhood Anxiety and OCD, which just came out was it April?
April 16th.
16th, that's right. Which we're recording this episode in April. It'll probably air in late May, early June. So wherever books are sold, I'll have that book in the show notes, as well as your information for people to research and learn about you and your work. And I really think this is a great practical way for parents to get information. They didn't go to grad school. There aren't doctors. It's okay. Getting a little bit of this information, which is distilled into a readable format, is good and will empower you as a parent to be able to stop feeling completely overwhelmed when your child has anxiety, and get some ideas about where to start. So I appreciate that.
Yeah, that's our hope. Thank you.
Yeah, absolutely. It's been my pleasure having you on the podcast, Dr. Whiteside, and I wish you luck in all the studies and getting this stuff published and getting your word out there.
Oh, thank you so much for having me. It's been a joy.
And there you have it. This has been another episode of the Intentional Clinician podcast. If you're enjoying the show, please share it with people you know. I would surely appreciate it. Or take just a minute to give us a rating on iTunes. As most of you know, I am passionate about preventing future violence in the United States. My colleagues and I have started a nonprofit called the National Violence Prevention Hotline, a 501c3 organization. We are endeavoring to gain funding and collaborators so that we can start a 24/7 hotline and chat line to reach potential perpetrators before they act violently. It is a bold effort to save lives and curb violence by working to connect with potential offenders while they are in the planning stages of violence, help to de-escalate them, and provide resources so that they can get appropriate professional help. The National Violence Prevention Hotline is looking to open up a conversation about violence in society, the causes, and the solutions. You can learn more by visiting our website, www.violencepreventionhotline.org. Join us online by signing our petition on the website, sharing the website with your network of people, donating to the cause if you like, and you can now even write your congressperson from our website with a simple form. I've said it before and I'll say it again. If you are a therapist looking for ethical and excellent medical billing services, check out therapistbillingservicesllc.com. That's www.therapistbillingservicesllc.com. Billing services created by therapists for therapists. If you're looking for an EMDR International Association consultant, I am a consultant and I can provide you the 20 hours you need to become EMDRIA certified. I have groups online and in person, and I do individual consultation. Just send me a message at the website and I'll get back to you. If you want to get trained in EMDR therapy, check out the great training opportunities with EMDR Training Solutions. I've worked with them before and they are phenomenal, so register today. If you are in need of counseling, do not hesitate to make an appointment at a local counseling center in your area. You can also make an appointment with the excellent clinicians in the Grand Rapids, Michigan area at Health for Life Counseling and the Trauma Informed Counseling Center of Grand Rapids by visiting www.healthforlifegr.com. The recording you just listened to consists of the personal opinions of Paul Krauss and his guest, and while these are based on the literature they have read and the experience in their fields, this should not be viewed as a definitive opinion on any subject. Listening to this podcast is not a substitute for treatment. If you're in a crisis, please dial 911 or the National Suicide Prevention Lifeline at 988. You can also text 741-741 and a live trained crisis counselor will respond. Did you know you could support your local bookstore by shopping at www.bookshop.org? You can order from the comfort of your own home online while supporting local brick and mortar businesses near you. If you are a therapist and you are not a member of your national or local therapy organizations such as the American Counseling Association or the American Mental Health Counselors Association, please get involved, at least pay the dues. It will help the lobbyists in our field keep us from becoming gig workers. And of course, there's the bonus of increasing mental health education around the United States and helping people understand what counseling is and promoting best practices within our profession. Until next time, I wish you all a safe and peaceful week.